There is minus 20. Oh. Honestly, I'm very happy to be here because here is one in this room. So, my presentation will dedicate some aspects of choice of selection between different strategy of treatment of stress urinary incontinence. Yes, looks to the definition of stress urinary incontinence created of ICS. There are symptoms and signs and condition. Symptoms, it's things which patients will tell us during visit. Usually it's loss of urine during exertion or sneezing or coughing. It's a very often condition. I will tell you about this. And signs, it's things which we will see during examination of patient. Usually it's loss of urine during Valsalva maneuver. Because Valsalva maneuver, it's increase of abdominal pressure. And condition, it's ordinamic term. During feeling testometry, we can see involuntary leakage of the urine during increase of abdominal pressure. In case of stress urinary incontinence, it's increase of abdominal pressure during Valsalva maneuver again. In case of urgency incontinence, it's increase of detrusor vesical pressure because involuntary detrusor contraction. It's a different kinds of post-incontinence, you know that. What about epidemiology? I mean, the prevalence of stress urinary incontinence. It's as for me, it's interesting and a bit difficult question because in the United States, 25 million women suffering of this condition. In France, more than 65,000 surgery every year. I mean, tapes implantation, transobturative tapes, mini slings. I know situation in France very well because I have a good relationship with French gynecologist, Professor Eric Vautrin. And now we're preparing the release of our joint magazine, Perineal Pain and Pelvic Journal. So, on this reason, I know situation in France very well. And in Russia, Tatiana will tell you about situation in Russia, but in Russia it's very strange because only 2,000 or maybe 3,000 surgery every year. But in France lives 65 million people. In Russia still live. I mean live, not surgery. I mean live 65
million.
Yes, million. And 65,000 surgery. One surgery per 1,000 people. In Russia, 145, yes, maybe 45 still live there, and only 3,000 surgery every year. So it's a very interesting situation. So, and more important for me, stress urinary incontinence more prevalent in young ladies. You can see result of this trial. It's a stress urinary incontinence, urgent incontinence, and mixed. It's a young lady from 30 till 40 years old, and this situation 40 and 50 years old, and in case of older ladies, prevalent mixed incontinence or urgent incontinence. So this condition very important for young ladies. One more trial. It's a United States trial. 45 responders. I think were housewives. They were housewives, and 37% of urinary incontinence, all types, not only stress urinary incontinence, all types, but it's problem. That's prevalence in Europe. Very interesting. Why in Spain only 15%, in United Kingdom 32, Germany here 34, and France 32. Why in Spain only 15? I think It's because not good educated women in Spain, not well educated. The same situation in Russia. Ladies are not good educated, and unfortunately gynecologists, most of gynecologists not well educated as well. Only this reason, in Spain only 15% and in Russia less than 15% of incontinence, in fact.
Where this survey has been done? I mean, it was done through general practitioners, through gynecologists, through urologists.
I don't know what about this trial, but it's a very good question.
Because in general, it depends on the medical situation and the organization of the medical system. In some of the countries, as for example in Bulgaria, some of the ladies can easily complain to, let's say, their general practitioners, and they never reach urologists or gynecologists who are able to treat the condition, but they are kept with the general practitioners, and that is how the reported level is relatively low, but the real situation is completely different.
Absolutely agree. I think good idea to perform phone by phone, or I don't know, maybe during a prophylaxis examination. Yes, because it depends of doctor information. Yes, I agree with you. Absolutely. And I think it's very interesting because stress urinary incontinence more prevalent when some chronic disease, more than even hypertension. I show you those slides because I was going to explain that stress urinary incontinence is a problem, and of course maybe it's important. It's a potential market for doctors, for companies, and we have to be there. Impact stress urinary incontinence on quality of life. So this trial. In this trial was a visual analog scale. It wasn't quality of life, but it's easy for field for responders, because quality of life questionnaires sometimes it's difficult for you. So you can see health patients has a not zero. Even a health patient's not happy. Stress urinary incontinence has impact on quality of life. Huge incontinence has a higher point impact to quality of life, and mixed, of course, higher. And of course, ladies with injury couldn't be happy. And I hope we have to help them, because I told you, usually it's young persons, young ladies, and it's important for all of them, for most of them, to be beautiful, to be attractive for husbands, for boyfriends, for men. And I'm afraid ladies with same injury couldn't be attractive for men. So I have had patients, and she was married, and during dancing with husband, loss of urine was problem, and it could lead to divorce. So it's important for ladies. Oh, myths about stress urinary incontinence. In Russia, I'm listening too much myths about stress urinary incontinence. Of course, it's a normal part of being woman. It's a normal part of aging, and surgery only one way to treat stress urinary incontinence. my mother suffering of stress urinary incontinence, and I have it, so it's normal situation. My colleagues from ancient Russian city, Vladimir, invited me for surgery of stress urinary incontinence, for slings, for bulking agents, injection, for everything. And I saw a patient there, lady is 50 years old, and I've asked her, how long you suffering of stress urinary incontinence? And she told me, I'm suffering only 1 year. But before it was normal situation. I've asked, what do you mean? Which situation normal for you? And she told me, I used only 2 pads a day. Only 2 pads. But now it's normal situation. Why? Because everybody in the office, she works in post office, everybody, ladies in the same age in the office experience the same problem. So, but as for me, if I used 2 pads a day, it was just a catastrophe for me. But I don't know why for ladies it's normal situation. And before surgery, she used 3 or 4 pads a day, so it was not normal situation for this lady. It's factors, risks for stress urinary incontinence. First of all, it's obesity, increased body mass index, significant risk factor for stress urinary incontinence. Menopause, it's of course because estrogen receptors in the urethra, muscles of pelvic floor, and trigonum. It's very interesting for me because urgent incontinence in menopause, I told you, I showed you slides, prevalent in old ladies in menopause. And I think we have to find a way for treat all conditions, both conditions. I mean, stress urinary incontinence in menopause and urgent incontinence.
Well, the other is the normal birth. If the ladies gave birth in normal way, traditional way.
Normal deliveries.
Yeah, the normal delivery. They are in the risk group. If the delivery was through cesarean.
Yes.
Cesarean section.
Yes. I understood.
Then the risk is relatively lower with these ladies.
Yes, of course. But I believe normal delivery.
Yeah.
Age, of course, but stress urinary incontinence prevalent. I told you in case of younger women, and urgent or mixed urinary incontinence in older women. Race, I don't know why. Maybe it's genetic factors, genetic situation, and thank you for remarks. Childbirth and pregnancy. Of course, during normal delivery, it's risk factors not only for stress urinary incontinence. Maybe you know pudendal neuralgia. It's a problem with pelvic floor dysfunction. Of course, in case of stress urinary incontinence as well. So, normal delivering sometimes lead to pudendal neuralgia and myofascial reaction and stress urinary incontinence. Normal delivering is risk factors for many pathological conditions. But of course, what could we do? Perform cesarean surgery for everybody, for every ladies. Who knows?
No, I'm just telling that considering the fact that most of the ladies are delivering through a normal way, so the group, the possible risk group is
yes.
relatively high.
Yes, of course. Maybe good idea, but it's controversial results. I saw one trial who reported about decrease of stress urinary incontinence in case of pelvic floor muscle training after delivery. But it was a single center, it was controversial trial, but maybe it's a good idea to perform training of the muscle after delivery. Maybe yes.
Yes, and they also use some yoga training, etc.
Yoga, Kegel, yes, left back.
But not, unfortunately, not all of the women are doing this. So
yes,
Yeah.
because it's difficult to have a baby and yoga the same. And like, in the kitchen, something good things for husband, of course, is difficult. And smoking and chronic lung disease. So now, unfortunately, in Russia, I hate it. Many ladies smokes cigarettes like this, like this lady. It's not Russian lady, but in Russia, unfortunately, the same situation. And you can see with trial results. Smoking leads to increased risk of stress urinary incontinence. I think even smoking doesn't lead to stress urinary incontinence. I think it's a bad idea for ladies, of course. And hysterectomy, of course, it depends of a kind of hysterectomy. Vaginal hysterectomy, increase of risk of stress urinary incontinence. Abdominal approach, not the same, less risk of stress urinary incontinence. Now in Russia, vaginal hysterectomy, it's I'd say fashion surgery, but we will see results, long-term results. All of you know pathogenesis. Let me just tell a couple words about pelvic anatomy. You know, in my opinion, key point for normal continence, cooperative, I'd say collaborationship, pelvic ligaments and muscles, because it's not only with ligament. In peristaltic anatomy, PNA, with pubo-ureteral ligament doesn't exist, but in fact, cooperation works of all muscles, all ligaments lead to continence, urine continence. Papa Petras published absolutely outstanding book about integral theory. This theory explains how does it works. So, just a moment. All of you know transmission of abdominal pressure. In case of suddenly increase of abdominal pressure, with pressure equally works in the urethra and the bladder. For this reason, pressure in the bladder less than pressure in the urethra. And very important two things: normal urethral support and sphincter competence. In case of loss of urethral support or sphincter incompetence, during sudden increase of abdominal pressure, this pressure works only in the bladder, not only in the urethra. All of you know this situation, but we can see a loss of urine. In my opinion, key point is urethral pressure. Pressure in the urethra always should be higher than in the bladder. It's a key point for continence of the urine. I guess it's a picture of Russian painter, three ancient Russian heroes, and three ways before them. First of all, it's pelvic floor muscle training. All of you know Dr. Kegel. He was not first at this kind of training, but he was very active. He was very enthusiastic. On this reason, this method called training. I believe in pelvic floor muscle training, and I will tell you about this, but it's difficult. You're absolutely right. It's difficult for ladies perform every day training for pelvic floor, and in the gym, of course, for good shape of their body. Second, it's sling surgery. I mean, some kinds of sling surgery and tapes implantation, and of course, bulk injection. It's a third. Pelvic floor muscle training. Look at this slide. Kegel cones. When I was young urologist in their public hospital, it was very interesting for me to treat ladies with stress urinary incontinence and other conditions. And I learned that in their old Russian factory, these cones, because it wasn't in the Russian market, made of stainless steel, and my patients use it, and most of them told me, I'm not happy with stress urinary incontinence treatment, but I'm happy with sexual life. It's true, it's true. So I was happy because I helped them in their sexual life, but I didn't help them in stress urinary incontinence. Absolutely. It doesn't work. In my experience, in my practice. Maybe your opinion is different. Transcutaneous electrostimulation. So it's a Kegel 8. It's an interesting device from United Kingdom. I was in their factory. This factory, so honestly, factory in the China, as usual. Yes, but developed an implant in the Slagstead farm, close to Winchester. I know creator of this device, Mr. Nigel Verity. It's interesting for treatment of urgent incontinence. It's interesting device for treatment of pain, of course. It's interesting device for treatment of sexual dysfunction, some kind of sexual dysfunction. But as for me, it's difficult to tell patients. Usually, patients who are suffering of stress urinary incontinence, it's usually not first visit for this patient to urologist. In my practice, this lady is suffering many years, and first of all ask a gynecologist. And in my practice, in Russia, maybe not in Germany, not in your countries, but in Russia, gynecologist trying to treat some urogenital infections, ureaplasma, chlamydia, Gardnerella, a lot of them. But no one of them trying to treat stress urinary incontinence. And this lady is sick and tired of these conditions, because it's difficult conditions for ladies. And it's difficult for me to tell these ladies, oh, now you have to perform every day, 2 times a day, a training of your pelvic floor muscle during at least 6 months, and who knows about results. Absolutely no guarantees about results. On this reason, for treatment of stress urinary incontinence, maybe sometimes it's good, but I told you, in my opinion, it's a good idea for prophylaxis after delivering. My opinion. So, sling surgery. All of you know, slings create normal urethral support and keep urethra in the zone of transmission of abdominal pressure, equal transmission of to the bladder and to the urethra. In my opinion, first sling surgery, it was martial machetic runs, you know. It was surgery without some tapes or meshes or synthetic prosthesis. And third way, it's a bulking agent injection. Bulking agent create some infravesical obstruction, but not critical for this patient, infravesical obstruction. Just, how can I say, maybe suitable for this clinic condition, infravesical obstruction. And pressure in the urethra higher than in the bladder. Back to sling surgery, you can see retropubic urethropexy, martial marchitic runs, and Birch surgery, Birch operations. You know, it was abdominal approach and then laparoscopic approach. It works, but you told which problem of incontinence, it's a collagen, general collagen problem in pelvic floor ligaments and muscles. On this reason, we can try to slings with tissue, with muscle, with ligament, but with ligaments and all pelvic floor changed. And you know, results controversial. Short-term results good, but long-term not good. And now in our clinic, maybe Tatiana agree with me, maybe not. Birch and Tatiana, do you know about martial marchitic runs in our hospital?
No, it's totally different. Maybe
So-
with operations.
Thank you. So, I think so. What about your hospital? Do everybody? No. And many artificial and autological slings were created. It was homemade slings. I have started with the same slings. I've cut hernia meshes because it was very expensive in Russia to use G&G slings, TVT and TVTO. So it's secret, but I cut hernia meshes and implanted them. It works, but in case only one problem with a lower, with judge after this surgery, it lead to loss of diploma, loss of practice, you know. So honestly, it's a bad idea. It's autological slings. It's a controversial situation. Very famous Russian doctor Dmitry Pushkar used it, still used, but only for published in the Neurourology and Neurodynamic and other magazines. And Ulfsten invented this synthetic tension-free vaginal tape in more than 15 years ago. And it was, I'd say, a revolution in the surgery, urogynecology surgery. And later comes TVTO. Now, suprapubic TVT completely, not completely, but usually disappeared. And most of surgeons used transobturator approach. Maybe it's not good. We will discuss it a little bit later. Now we have two surgery, suprapubic and it's a good idea, transobturator, and of course now we have mini slings. Mini slings is a different, it's beyond of this presentation, of course, but it's interesting. And look to the way of the TVT implants. It looks like Triumph. First surgery was performed 15 years ago, and absolutely no long-term dates. And despite this fact, tapes become very popular, especially for young surgeons. Because I was young surgeon last time, and I was very enthusiastic. It's a short learning curve. It's a I thought it's simple surgery. Now I'm not young surgeon, and now I know in my opinion, every surgery not simple.
No, definitely.
Yes, every surgery is a surgery. For example, once I performed, it's not urogynecology surgery, it was andrological surgery. I performed so-called selective denervation of the penis for treatment of premature ejaculation. That was simple surgery. And after this surgery, great bleeding, and patient left hospital, and during his way to home, he has got strong bleeding, and of course, my competitors in the hospital, urgency hospital, told him, "Oh, so it looks like necrosis, because hematoma looks like blue penis of this patient." This patient was impressed, so it wasn't a problem for me. But a couple of days I was a bit nervous. So every surgery, it's a surgery in my opinion. And less invasive, yes, it's less invasive, incomparable with martial machete crowns. But despite this fact, it's a surgery. It's a day surgery sometimes, and now over 1 million tapes procedure performed. So it was very popular situation. But a little bit later, you can see so not good quality of image, but in the published of every doctors, absolutely outstanding results, outstanding situation. But in the FDA database, picture a bit worst. Percent of complications higher, even with deaths, even a situation with transobturator surgery, and of course in case of total amount of complications. But in the literature, everything okay. And now, what we can see now? Of course, it's not in every cases, but statistical data with complication not prevalent, but every cases, it's a tragedy for every woman, for every ladies who got erosion of meshes. It's a tragedy because it takes repeated surgery, not one, maybe 2, 3, and if you one time try to cut meshes from tissue, you will remember this surgery all your life, because it's very difficult. Of course, less than 10% of tapes undergo erosion, but in my opinion, it's enough. And now, it's many claims to courts. If you print in the Google, ask mesh complications, links complications, you can see many advertisements of United States alternates, United States lowers. These lowers earn enough money now in this situation with erosion meshes and another complication. And now, United States court make a decision. G&G have to recall all meshes. I'm not sure. I'm sure only in prolift situation. I'm not sure in tape situation, but I think so. It's interesting fact, but in Russia, prolift still in the market. And I was 3 days ago in Turkey, prolift still in the market. I know in Europe not, but.
But when was this decision taken by FDA?
I'm not sure, but my colleagues from United States sent me 6 months ago, maybe 6 months ago. Yeah. Only in one state, Alabama. I don't.
You can find it on the FDA. If you
yes,
go on
yes.
the website of FDA, you find the data exactly, and they start in Alabama and they become over all the other regions.
If you wish, I have it in my laptop. I can send you right now.
Yeah.
This letter, because I have it. So, but now it's strange. J&J meshes in the market. Maybe because J&J it's a rich company, it's a big shark. I think.
Yeah, yes, that's true.
It's true. In Russia as well.
But excuse me, the tapes are not part of it. This is only for vaginal
Yes.
reconstruction. So the tapes are still in the
Yes,
market.
thank you. I'm not sure, yes. But maybe tape will come, maybe not.
It has been 12 years in the market, so I don't think the problem is evident like the vaginal mesh. So for the tape is not as a big issue.
Maybe it's. Maybe it's. Now, slings and the meshes future a bit in the fog. I chose this picture because one of theory which explain how continence works. It's a bridge theory, so it's a bridge in the nebula. What about in the future? First of all, maybe I mean the perspectives of the meshes. Now, mini slings. My good friend and teacher, Professor Batran from Aix-en-Provence, created mini slings. Name of this mini sling, Just Swing. It's adjustable. Maybe it works, but in my experience, all mini slings implantation results depends of condition of obturator membrane and muscle, because Just Swing anchor have to be an obturator membrane, and if this membrane in bad condition, we can lost anchor. I saw this because I have experience of maybe 30 surgery of Just Swing. It's French sling. It's a barred sling with anchor as well, and the same situation. Now GEG create mini sling Abreo. It's just a cut meshes of for TVTO. It's absolutely usual mesh, but just a cut. Who knows? In my opinion, mini slings have perspectives, but a bit limited perspectives. And PLJ scaffolds. As for me, it's a very interesting scientific point. Now I'm trying to develop this kind of scaffold for mesh and for tape. It's a fully absorbable during 2 years, but after first presentation, as for me now it's a bit doubtful, because you told me that it could lead to the special macrophagal reaction. But now I'm in the stage of the step of animal model, and if you wish, I will tell you later about my results, my impression, my opinion. But for me, it's interesting for experimental model, and we will see. Maybe now on this step, on this situation, best way it's bulk agents. Why? Because it's less invasive, because it's absorbable, because it's a real day surgery, but not real surgery. It's not surgery, it's very easy, very simple. I'm going to show you a couple clinical cases. Maybe it's good for us to discuss this clinical situation. It were two real patients, my patients. First of all, patients J, 39 years old. Symptoms: loss of urine during coughing, sneezing, exhaustion. Typical symptoms, you know, of this urinary incontinence. Pad test: 2 pads a day, and weight of urine in the waste pad 2 grams. Avoiding diarrhea, 11 nutrition per day. Questionnaire is, I will show you later, 9 points, and another questionnaire, 19 points. Urodynamic study: absence of involuntary contractions, maximal systematic capacity 280 milliliters. Of course, I thought that it's stress urinary incontinence. You agree with me? It looks like stress urinary incontinence.
But look at the age, 39.
It's a normal age for stress urinary.
Yeah.
It's a suitable age.
Yeah.
Yes. And this questionnaire, you can see domain dedicated frequent and urgency point score. It's low, and domains dedicated stress urinary incontinence, it's higher. No pain, no problem with ventricle bladder. It's another questionnaires, impact of quality of life. It's a moderate here. This patient, she wasn't happy, but a bit a normal situation. So, I performed TVTO implantation. It was not GEG meshes, it was, I've forgotten, I think it was Russian meshes, slings, sorry. And results, yes, all symptoms of stress urinary incontinence finished, but suddenly I saw urgency de novo. And pad test, 3 pads, 65 grams, voiding diary, 24 micturition
More
a day.
than before.
Ah?
More than before.
Yes, 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 of course. And questionnaire score higher than before both questionnaires, and urodynamic. And one involuntary detrusor contraction with loss of urine and maximal systematic capacity 165 milliliters. So you can see questionnaires. Now both domains dedicated frequent and urgency greatly score. Urinary incontinence domain less than before, and impotent. Now slightly problem with empty of bladder. You can see. In my opinion, it wasn't good results, and more impotent for this lady, it was good results as well. One more questionnaire, impact on the quality of life. You can see situation become worse. And absolutely outstanding results. Before was a some drops a day, and now just wave. It's good for surfing. I'm very happy. Yeah. I'm very happy surgeon. Yes, it was a real situation with my patient. It's not one cases. Sometimes it happens. And even best urodynamic evaluation not does make a guarantee for us about outcomes of surgery. Even if no signs of urgency before, after surgery we can see urgency de novo. Some hypotheses indicated this situation, but sometimes it happens. And I'm happy because I live in Russia. If I live in the United States, I've lost my diploma, or I can pay penalty, or I can feed this patient, her husband, her children all my life, all her life. Yes, sometimes happen. So, do you have any comments? Any experience? No. Case number 2. So, the same diagnosis, it was real stress incontinence, and TVT surgery transobturator was performed, and results. Stress urinary incontinence was stopped, but complication. It was very important for me, and interesting complication, strong obturator pain, obturator muscle syndrome. Maybe all of you know myofascial reaction of pelvic floor muscle. It's a condition. Now, it's an interesting part of urogynecology. Before, many doctors, and me as well, think about, in case of pain, pelvic pain, it's an inflammatory disease, adnexitis, or in case of men, prostatitis and cystitis and endometriosis. It's not inflammatory, but in the pelvis. But now we know that myofascial reaction, myofascial syndromes lead to pelvic pain. Looks like inflammatory condition. And last dates, especially in France, because in France and in the Spain it's very popular part of urogynecology. more than 90% of inflammatory disease, it's a neofascial reaction. Sometimes after transobturator implantation of tapes, because muscles and membrane obturator muscles perforated during surgery, and afterwards you can see symptoms, sensations, foreign body in the rectum, pain in the back of this, vaginal vulvar pain, ureteral pain, and in the entire pelvic floor. All symptoms were in my patient, this lady. So, what I have to do? At first step, I used it was not first step. I used painkillers. It doesn't work well. Doesn't work enough. Next step, I have called to my colleague from Spain, Dr. Fernando Izza, and asked what I have to do. He told me, try to infiltration of the muscles with local anesthetic and steroid. I did it. I have made infiltration of obturator muscle, both of them, for half a day, for 12 hours. It works. But then symptoms back again. It's not good. And I've tried to perform a so-called block injection, block of pudendal nerve, ultrasound guided block injection. It works. But patient wasn't happy because perform every week block injection, transvaginal. It's not good. It's painful. It's invasive. So in the end, I tried to cut the tape and incomplete. All of you who just perform one surgery for cutting mesh know it's very difficult to find tape or mesh in the tissue and cut whole mesh. And now this patient, she's not happy. Situation become better, but not full. This patient not full recovery. So all of you know bulking agent advantages. In case of fail of procedure or serious side effects, situation get back after absorption. It's a reversible procedure, absolutely. Absence of urgency de novo, and in case of increased pressure in the bladder, pressure in the urethra become higher after bulking agents. So sometimes this procedure can treat of urgency incontinence. Of course, it's not first line. First line, you know, it's antimuscarinic, but sometimes it works. Absence of general anesthesia, it's impotent. In my opinion, it's a cost-effective procedure, I'd say, and good, suitable for private clinics. Of course, very, very good, because now many private clinics in Russia, and I hope in your countries as well, and less fear of surgery for patient, as for me, and for surgeon as well, less fear. Not absence, but less problem with potential problem with lawyers and judges and courts, and simple procedure, short learning curve. And which bulking agent? I have experience only 3, and of course Urodex. I started with autologous fat. I have 2 experience of fat. First of all, it was in penis enlargement. It was failed, absolutely. It was terrible surgery, and 2 cases paraurethral injection of fat. Difficult at first and non-stable, absolutely, because it's a short-term effect. I can't tell something about my experience of this agent, but I can tell you about polyacrylamide and Colost. Polyacrylamide, it was a Russian dump loose bulking agent, maybe an amino agent. So, as for me, it was millennium, and I was young surgeon and very enthusiastic, just like this. And I started in my practice in the public hospital, injection of dump loose. First of all, it's not easy procedure. Why? It's difficult to see correct position of the needle, and 2 times I've performed bladder. Not strong problem, of course, because it's a needle, but it's not good. And second problem, it's migration of bulk. Looks like this. On this reason, this bulking agent not good. I mean, long-term results, of course. And after migration, unfortunately, I didn't find a picture, but I saw this. Okay, just a moment. I saw this picture, just a conglomerate after injection. And you can see in ultrasound migration of the bulk. Bulk infection, and polyacrylamide non-absorbable. It's a not reversible procedure. If in case of fail, bulk in the tissue, stay in the tissue for all life of patient. Second was cross-linked collagen. In the market, in the Russian market, contingent, it's BART collagen was not, but Colost, it's a Russian bulk, was in the market. So my experience, allergic reactions, you can see 2 syringes in their set. First of all, it's for test. Yes. Small volume of bulk for test. But all of you know, test could lead to sensibilization.
Yeah, because it's animal source.
Yes.
Collagen is animal source, and we have the experience. You make a test, wait 4 weeks, negative, you start reaction.
Yes, of course. Yes, of course.
Yeah,
of course.
you make a sensibilization with the body to this collagen.
Yes, and next rotation
It's
lead
not,
to the
not secure.
Of course. And now contingent, BART remove contingent from the market, and Russian collagen in the market, still in the Russian market, but I never, I stopped use. And it's true, injection need physical efforts. Doctor should be like this, because you know we have to preheat collagen, and I started preheat in my hand. Absolutely not enough. I bought a special thermostat for preheating for temperature of the human body, and not enough. Yes, I have to increase temperature, but in case of high temperature, collagen dead. I changed needle because for big diameter needle, it's a bit dramatical for patients. So, and more important, collagen not stable, at least Russian collagen not stable in the tissue, and it takes repeated injection, only 6 months, maximum 6 months, usually 3 months.
How about the implantation of dump loose? Was it easy to perform, or it was again hard?
Not easy. It's difficult, of course, and I thought it's difficult to put needle to the right position. I used stethoscope for see like bulk move urethra wall inside, but sometimes it's difficult to make like this, because it was weak situation and poor situation in Russia, and in my clinic, public hospital, wasn't stethoscopic monitor, so it was like this. It was difficult, true, it's true. And results of collagen I'm not satisfied, my patient is not satisfied as well, and it's not cheap. It's expensive and free injection for, of course, Professor Sinikova from Moscow told me that after 3 injections around the urethra created cuff, collagen cuff. I don't know, maybe yes, maybe not, but 3 injections, it's a bit expensive, and it's not good for patients. So, Urodex. About Urodex, will tell you Tatiana, because she has great experience of Urodex in Russia, in our hospital. But my impression for us doctors, advantages, absence of general anesthesia, and I think it's important. Childbirth is possible after meshes. Childbirth not possible, we know. But I told you it's young ladies, and who knows? Maybe she divorced and marry again and wish new baby. And after mesh implantation, it's difficult. Of course, we can perform cesarean, but not good. So childbirth is possible, low risk of complication. I saw complications in my experience. Only one, acute urinary retention. But it was my fail, I know, because it was she was a VIP patient, and I tried to make a good impression and gave her Vesicare in addition to the Urodex injection. And after injection and Vesicare, early in the morning, 5 a.m., I got call by phones, and during next week, 2 times a day, I visited this patient because she was a VIP patient for intermittent catheterization. So, but sometimes it happens. What can I say? Sometimes it happens. You know migration, and you told us you performed very nice lecture about fibroblasts, growth, biocompatible. I hope absence of allergy.
Yeah, it's true. But by the dextromeres, there are no allergic risks, and the hyaluronic acid is free of any toxins, and we have no risk of allergy. Both of them, they are without it.
It's very important because now a lot of allergic reaction for many antibiotics, for a lot of.
And the dextromeres are get from dextran. Dextran get cross-linked, and then we have dextromeres. So there is some free dextran in it. What we are doing, we are buying the dextromeres from a big pharmaceutical company, and then we are washing before 10, 15 times until no free dextran is anymore in the last washing waters. So to avoid the problem of the reaction against the dextran.
Oh, outstanding.
Yeah.
Yes. And really a simple injection technique. Really, it's a good idea to create this device for injections. It's a big help for doctors.
Excuse me, can I just ask about the fibroblast forcing growth? Based on what?
They start by the positively charged surface. This gives an electrical, an environmental, and we have the first clinical data shown by an American doctor showing how it works. Immediately after this implantation in the tissue, the soft tissue, they attract the macrophages. And then they are surrounded, and the cascade starts then to build up fibroblasts, and from this it's on to the collagen fibers.
But is that something showed on the Urodex?
Yes, we
on
have this,
animals?
yes.
Or on?
No, this is shown on the positively charged dextromeres, the soft tissue. And we are using the same as they are used in this clinical data.
But there's no animal study specifically looking at
animal
that?
study, yes, animal study.
There is?
Yes.
Showing the fibroblast
Yes.
formation.
Yeah.
So, some conclusions. First of all, I don't tell you stop tape surgery. Of course not. But in my opinion, we have to be careful before and during tapes implantation, because Urodex reversible. Tapes, not reversible. If we implanted tapes or meshes, this material, with tapes and meshes, will in the body of ladies all her life and all